Okay, Dr. Patel's here. Can you guys hear?
Yes, we can.
Awesome.
Yes. Can you hear us?
Yes, we can. We can hear you guys. Hi,
Okay,
this is
great.
Dr. Patel. Sorry
Hey,
for
Dr.
running
Patel.
a little bit late.
That's okay.
How's everybody doing today?
Good. We're doing great.
Thank you.
Awesome. So I'm not sure if this is going to be new information for you or a review, but what I wanted to do today is go through kind of the initial evaluation of someone that presents to established care with you that's newly diagnosed with HIV.
Okay, great.
But I did want to go through a little bit. Can you see the slides? Can everybody see the slides?
Oh, yes. Yes, I'm sorry. We do see the slide.
Perfect. So I wanted to go a little bit into a snapshot of what the HIV pandemic looks like globally and then locally as well. Go through some of the changes that have been made in the past probably 10 years in terms of screening, diagnosis, and then look at what happens to an HIV-infected individual if there's no intervention. What is the natural course of untreated HIV infection? And then go through the evaluation of a newly diagnosed patient. What are the kinds of things we would want to know on history? What are the kinds of things we want to look for in physical exam? And look at some of the common opportunistic infections and how we can prevent them. I'm going to touch very briefly on antiretroviral therapy. That is a whole session in and of itself, but what I'll go through are the kind of the first line indications for ART in patients that are treatment naive.
Okay.
And stop me at any time because I don't really want to hear myself talk the entire time.
All right.
Okay.
Thank you.
So this is a snapshot of global HIV. This data is a little bit older, but the proportions are still the same, which is there are about over 35 million individuals living with HIV, adult and children, in the world. The majority of these patients are going to be in the sub-Saharan African region, but you can see that there's over 2 million individuals living in North America and Europe with HIV as well. When we look at the United States, sometimes we think of HIV as a bi-coastal phenomenon, you know, West Coast, East Coast, but it's really more of a southern disease. So this is the most recent data from 2015, looking at the rates of diagnosis. So these are new cases of HIV among the population. And you can see that in Texas, we're, you know, as purple as it gets. So the rates of people being diagnosed with HIV are high in Texas, and those living with HIV are considerable as well. So when we look at just Texas, this is data that kind of gives you an idea of what's going on locally. So the light blue line are the folks that are newly diagnosed with HIV, and there's a little bit, you know, there was a spike in the late 90s when there was more testing done, and then it's been relatively stable over the past 10 years, though there are increases among certain very specific populations. So, you know, for example, young African American women are being diagnosed with HIV kind of disproportionately at this point. Also, the green line tells you deaths among HIV, and so with highly active antiretroviral therapy, deaths tremendously came down in the mid-90s and have been pretty stable. This is death from any cause, so it's never going to be zero. But there was a precipitous decline when antiretroviral therapy was widely available. And then the red line shows you the number of individuals that are living with HIV in the U.S. And, you know, the Beaumont, Port Arthur area has been kind of a hotbed for new infections. So you guys are kind of in the thick of things there. When we look at rates of newly acquired HIV in infants, we made the most tremendous amount of impact here. So you could see that this peaked in the early 90s and is incredibly low. At this point, if there is a child that is born with HIV in this country now, it's a big deal because in most states there are no children that are newly that are infected with HIV at birth anymore. So we've done a really great job in testing pregnant women, getting them on treatment, testing babies, and really globally there's been a lot of improvement in preventing mother-to-child transmission of HIV. So I wanted this to be as interactive as possible, even though I can't see you guys. So this is, I've embedded a couple of questions and cases in here. So this is our first question. Which of the following patients should be screened for HIV? A 19-year-old female who reports having protected sex. B, a 63-year-old male with no past medical history or risk factors. C, a 30-year-old male who has sex with men. D, a 42-year-old male who is an IV drug user with a negative HIV test 2 years ago. And E is all of the above, and F is C and D only. What do you guys think?
All of the above.
All of the above.
Okay, that was too easy. I'm going to have to make it harder for you guys. So that's correct. The CDC put out recommendations in 2006 advocating for routine HIV screening of adults and adolescents and pregnant women in all healthcare settings in the U.S. Primary care clinics, STD clinics, ERs, inpatient, outpatient, everything. And they recommended ages 13 to 64 be screened. And so this is for one-time, lifetime screening. The U.S. Preventive Service Task Force has slightly different numbers. They recommend screening from age 15 to 65. And the American Geriatric Society actually recommended screening up to 75. So the screening used to be based on a very complicated algorithm of if we thought that someone was at risk for HIV. And it turns out that we're not very good at assessing that, and patients, we think that patients are at lower risk than they really are, and it turns out that patients think that they're at lower risk than they really are. So it's no longer risk-based. It doesn't matter. If you're a human being between those ages, you should be screened and tested for HIV at least once in your lifetime. And the other thing the CDC recommended is that the general consent for medical treatment should cover HIV testing. So I don't know if many of you remember, it used to be that we had to have patients sign an individual consent form just for HIV testing, and that's not the case anymore. Patients should be told that they're being tested and given the opportunity to opt out if they want, just like with any other test that we do, but we don't have to go through the extra hurdle of having them sign a specific consent form. So even though these guidelines, these recommendations came out in 2006, it really wasn't until 2013 that the U.S. Preventive Service Task Force, which tends to be pretty conservative in terms of guideline recommendations, came out and said, yeah, I think we agree. But if you look at the uptake of HIV screening in the general population, it's incredibly low. We're not screening enough folks, and it hasn't become the same, it really needs to be the same as, mammogram and colonoscopy and pap smears. We need to think of it the same way, but it's not quite there yet. There are particular individuals that are at even higher risk that need to be tested annually. So these are patients who are IV drug users or are sex partners of IV drug users, people who exchange sex for money or drugs, sex partners of HIV-infected individuals. So those top three, I think we're pretty good at being able to recognize these people are at super high risk. But the last one is, I think, where we may be missing patients, and this is any person who's had a change in their sexual partner since their most recent HIV test. So that means that we need to be asking about sexual history in order to know if our patients are at risk or not. And I don't know about you all, but the only time I have ever been asked about my sexual history has been when I was pregnant. I don't know what your personal experience has been over there.
Agree.
Agreed. Yeah, it's not consistent for sure.
Exactly. So in terms of why we screen people and why the recommendations change, there is what we call the HIV cascade of care. So of all the individuals in the U.S. who have HIV, only about 82% know that they're infected. So that means there are about 18% of people walking around with HIV that don't even know. And this is important because there are a lot of studies that have shown that just knowing that you are HIV infected triggers a behavioral change that can reduce the risk of transmitting HIV by 30%. So people are they're more likely to use condoms, they're more likely to engage in safer forms of sex, they're less likely to share needles. There's just something about knowing that you have it that can help others from being infected. And of the folks that, of all the folks with HIV, only about 66% are linked to care. A smaller half of those kind of stay in care. A third are receiving treatment, but only 1 in 4 is actually on appropriate treatment, taking it well with a viral load that's undetectable. So that's really only 1 in 4 individuals with HIV in this country that are well controlled. So this is why the screening guidelines changed, because we need to figure out who those unawares are, those people that are walking around who either don't know that they're at risk or have just never been tested. And then when we get them, we need to actually link them to care, keep them in care, get them on appropriate treatment until they have virologic suppression. So here's another case. 45-year-old male with a history of coronary artery disease, hypertension, presents to the ER with hypertensive emergency. The physical exam is notable for oral thrush, and this very eager beaver ER provider suspects HIV and does a rapid HIV test that's positive. So which of the following tests should be used for confirmatory testing for the rapid positive test for diagnosis of HIV in an adult? So A is the HIV RNA viral load, B is HIV ELISA, C is the Western blot, and D is DNA PCR. What do you guys think?
Western blot? Is it Western blot?
Yep, it's definitely the Western blot, but this is a little bit of a trick question. So traditionally, it's the Western blot. So the sensitivity of a lot of these rapids they're usually ELISA tests. They're incredibly sensitive, and what the Western blot does is it actually looks for antibodies to the proteins and then actually some of the actual proteins on HIV. So the antibodies and then the proteins as well. Viral loads are useful in some settings, but never for diagnosis unless you're suspecting acute retroviral syndrome, because there's about a 2 to 9% low-level false positive rate and variability between the assays. So it's not going to be as sensitive or specific as we need. So for a positive rapid or a positive ELISA, it needs to be followed up with the Western blot. And here you can see the sequence of some of the lab markers that we use. First, upon infection, because there's no antibodies that are being made by the individual yet, your HIV RNA viral load shoots up, and it's probably going to be the highest that it's ever going to be during the course of HIV infection. And then so that's about, a little bit more than a week. Within 2 weeks, you start having the P24 antigen production that we can start detecting from the HIV itself. And then much later, you get the antibodies. And so a lot of our ELISA tests look for the antibodies. And as you can see, first generation ELISA tests wouldn't be able to detect HIV until about 50 days later. And with each successive generation, that window period gets narrower and narrower. So now, at UTMB, early last year, we were still using the third generation ELISA. So that was only looking for antibodies. But now we're using, and the CDC is recommending, everybody uses a fourth generation test, which is a combination of the traditional ELISA looking at the antibody, but then also looking at the actual HIV antigen, the P24. So with that, the window is really, really narrowed. And with every successive generation that they come out with, the window period gets lower and lower. So if you're using a third generation ELISA, you do need a Western blot for confirmation. If you're using the fourth generation ELISA, you don't need the Western blot. So do you guys have an idea of which generation ELISA you use right now?
I honestly do not know. Cordella could tell us just instantly, but she's not with us right this minute,
Okay.
so I don't know.
Okay, well, just whenever, if you can find out, then I think that'll help figure out if you really do need a Western blot or not. The fourth generation ELISAs are relatively new, so a lot of places don't have them yet.
Okay.
So, so we have our patient who has oral thrush. What is the stage of HIV infection in this patient? So A, acute retroviral syndrome, B, recovery and seroconversion, C, asymptomatic HIV, D, symptomatic HIV/AIDS, or E, you need more information. What do you think?
You said the patient has oral candidiasis?
Yes. Mm-hmm. I think so. I don't know.
Right. If we, you know, is the patient on medicines, or is that, or D would be the obvious answer to me, but is that, but we need more information, I think.
Okay.
Honestly.
So no, I think that's a really great way to think about it. So oral candidiasis is usually a sign of immunodeficiency, but in and of itself, it doesn't qualify as an AIDS defining condition. If they had esophageal candidiasis, it does. And many times if we see someone with oral candidiasis, we will ask them, do you also have pain when you swallow? And if they say yes, we assume they have esophageal candidiasis. So you guys are right, definitely need more information.
Okay, thank you.
No problem. And then these are the stages of untreated HIV infection. So this is if there's no intervention, there's no antiretroviral therapy, this is kind of naturally what happens. So between HIV transmission to acute retroviral syndrome, there are a couple of weeks there. Acute retroviral syndrome is one of those things that kind of feels like a flu-like illness. Most people will have fever, lymphadenopathy, pharyngitis, and a rash. But because it's transient and it just feels like some viral syndrome, a lot of people don't get care during that time. And and when they do come in for care, you know, we think that it's just some viral infection that'll run its course and don't necessarily think about HIV, so we miss a lot of patients in this acute retroviral syndrome stage. But then in about a couple of weeks, the patient will start developing antibodies. And once they start developing antibodies, the viral load will come down a little bit, the CD4 will rebound a little, and then they have pretty much asymptomatic HIV. So being asymptomatic can really range in patients. On average, folks can be asymptomatic for about 8 years before they start developing signs or symptoms of symptomatic HIV or AIDS. And then from there, within a year and a half, they will usually pass away. So this asymptomatic HIV infection, there is a caveat. There are patients who represent less than 1% of all the individuals with HIV who are known as elite controllers. These are folks whose own bodies are able to suppress the virus. So when you test them for HIV, they'll test positive because they have the antibody and the antigen. But when you test their viral load, they'll be suppressed because their bodies are able to do that. And their bodies can do that for over 30 years, for a really long time. But then there are other folks that are also kind of in the minority that go through this entire spiral from transmission to death within 2 years. They're called rapid progressors. So even though we say on average it could be about 8 years, it really depends. There are some patients that are going to go through this very, very, very quickly, and then there's some that are going to stay asymptomatic for a really long time.
Okay.
And, you know, the way I like to think about the CD4 and the viral load is, you know, your patient is on a train and it's barreling towards the edge of a cliff, which would be death. And your CD4 tells you how far from the edge of the track you're at, and the viral load tells you how fast you're moving towards it.
Okay, that makes sense.
And this is the natural course of untreated HIV infection. You can see that the blue is your CD4 and the red is your viral load. So if you focus on the red triangles, the viral load shoots up, and then once antibodies are formed, it doesn't get suppressed usually, but it kind of goes down to a baseline, and it kind of lingers there until at some point there just aren't enough CD4 cells to fight the virus, and then you have a precipitous rise in your viral load. On the other side, the CD4, you know, you have a little bit of a dip in the CD4 initially, and then there's a little bit of a rebound, and then slowly over the course of many, many years, it starts to come down until a point at which it really can't control, it can't make more CD4s faster than they're being destroyed, and that's when they precipitously decline. Because HIV is, you know, I say it's an evil genius virus because it infects and kills the very cells that are supposed to detect and kill it.
Yeah.
So it's very tricky that way. These are some of the different types of signs and symptoms you can have with acute retroviral syndrome. Again, most people will be symptomatic, but you know, we may or may not get them during this phase. It can present as almost anything. There have been case reports of this presenting as something that looks like meningitis, or presenting with Guillain-Barré syndrome. So, but the big things are going to be fever, lymphadenopathy, pharyngitis, and rash. And the rash is one that's usually on the palms of the hand and soles of the feet, and it's maculopapular in nature. So this is the only time where if you're suspecting that somebody has acute retroviral syndrome, this is the only time it's okay to get the viral load. I mean, you would get your ELISA and all that kind of stuff, but it might be negative at this time. But your viral load should be over 10,000, and it's usually going to be over 100,000. So if you have someone who kind of fits the description of acute retroviral syndrome, sometimes they'll tell you that, you know, a couple of weeks preceding they had unprotected sex, or they were exchanging needles, or there's something that looks like it was consistent with the time course, plus they have signs and symptoms of acute retroviral syndrome, then a viral load that's over 10,000 is diagnostic in that setting. So actual AIDS is going to be CD4 less than 200 or one of the AIDS-defining illnesses. There are many AIDS-defining illnesses, and you can see they really haven't been updated since the 90s, but it really is any condition associated with severe immunodeficiency. Anything that looks like, you know, somebody young and healthy really shouldn't have this. Some of the other things to consider are if somebody keeps coming in with multiple bacterial infections, especially like bacterial pneumonias, look for an underlying etiology. And that in and of itself gives them an AIDS-defining illness if they have HIV. Obviously, candidiasis of anything kind of but the mouth. So invasive cervical cancer is one of those as well, wasting syndrome, and then all of the opportunistic infections that we think of, like so Mycobacterium avian, cryptococcal meningitis, toxoplasmosis, all of those things as well. Okay, so our patient gets treated for hypertensive emergency and oral candidiasis. He's asked to follow up with you to establish care as his new primary care provider, and this is your first visit with him. So what are your goals for this visit? How are you going to approach this patient?
I want to know what his sexual background is.
Yeah, that's going to be really important to know, and we're going to get like in the nitty-gritties of sexual history.
Right.
What else might you want to know?
Right. Viral load.
I did viral load, and then basic lab.
Yeah, liver enzymes.
What are the common barriers that HIV-infected individuals face?
What? Say it again. We didn't.
What are the common barriers that HIV-infected individuals face?
Oh, faith. Oh, well, yeah, it could be a lot. It could be anything from socioeconomic, like income, to the social aspects of their I don't know how do you say it, but you know, others don't know their status.
Yeah, exactly. Yeah, so those things become super important. So when I have a patient that's newly infected, I kind of have two kind of overarching goals. One is going to be psychosocial and the other is going to be clinical. And that first visit, the psychosocial is going to be way more important than the clinical because it's going to be like you developing the relationship with the patient that's going to keep them coming back and not be a part of, you know, the statistic of the folks that just get lost to follow-up. So you really want to develop rapport and trust, assess kind of what their understanding is. There's still a lot of misconceptions about HIV, that they're going to die no matter what, that everybody gets resistance. And there's still a lot of stigma and discrimination out there. So I usually, you know, let them know that this first visit is going to be about us getting to know each other because this is going to be the start of another long-term relationship. And that we're here for them no matter what, and that this is a safe space for them. And I usually just I start with, you know, how are you dealing with all this? And kind of go from there. And then get an understanding of like, okay, so since you found out you were diagnosed, I'm sure there are a lot of concerns going through your head, a lot of worries. Let's get them out on the table. You know, what are the kinds of things you're worried about? Because sometimes it's things that, you know, they feel like they can't have kids, which isn't true. They could have kids that are HIV negative, have long, healthy lives. A lot of them are worried about how they tell their family. So really getting a sense of where they are emotionally, how they're dealing with things, what their understanding of the disease is, and kind of clearing up misconceptions. And then being able to educate them on, you know, what it is, how HIV kind of works, how it's transmitted, and figuring out what their support system is. So if there's somebody who, you know, whose family is in Minnesota and they're here by themselves and they have no friends, I mean, we really need to build a support system around them. And then there's some folks that are with family but don't want to tell them or don't feel comfortable. And that's okay in the beginning, but over the course of the first year especially, we do a lot of work on, you know, getting them to feel comfortable enough to disclose to someone who can be there for them and support them. And then get an idea of if they know kind of how they were infected. A lot of patients will say, yes, I went to the Dominican Republic on a trip and I had sex with a prostitute there and that's the only, you know, and then 3 weeks after I felt like I had a flu-like illness and then I got tested. So some patients will be able to tell you kind of a specific incident or even person activity. And in teasing through that, you can also kind of talk about ways that they can reduce their risk of transmitting the infection. And then our patients with HIV typically also can have higher rates of depression and anxiety, higher rates of substance abuse, alcoholism, domestic violence. So we try to kind of see if they have any of those issues that are going to be barriers to adherence and get them referred to our wonderful case managers, to psychiatry, counseling if they need that. And then our clinical goals are going to be to look for other comorbid conditions. So along with HIV, there are other things that like to travel along with it, you know, definitely all the STDs, gonorrhea, chlamydia, syphilis, but then hepatitis, especially hepatitis C, but to a smaller extent, hepatitis B as well. Try to see if you can identify the level of immunosuppression. So if someone has if they have extreme wasting and they've lost 50 pounds, like that signifies that they probably have advanced immunosuppression.
Right.
And then you want to see if they need any opportunistic prophylaxis or treatment. And then all of that information gives you an idea of how quickly you need to start antiretroviral therapy.
Okay.
So in terms of history, some patients will actually tell you, oh, I get tested every year, and my last negative test was last year. And so that gives us an idea of chronicity and where they are kind of in that spectrum of untreated HIV infections. So we want to know when they were last tested, what their previous results were, if they had signs or symptoms of acute retroviral syndrome, if they had previous or current opportunistic infections, any of the co-infections, comorbidities, if they've been hospitalized for any reason. We want to get their vaccination records, and then what you would do for any other patient with past medical history and family history. We also do the 5 Ps of sexual history, so I usually warn them that, I ask about sexual history to every single patient, and it's really important for me to know so that I can figure out how best to help you. So, we usually ask about partners in terms of how many previous partners they've had, current partners, if they've already been contacted by the state to do partner notification, because the state does that anonymously, what their actual practices are, and we get very specific, do they practice receptive anal intercourse, insertive anal intercourse, do they use any protection, do they use condoms, under what conditions, because some folks will use condoms with, they won't use condoms with their main partner, but they'll use condoms with other people. So I think it's important to ask when they decide to use a condom, like what makes them use it instead of not using it. And then how they try to prevent transmission or pregnancy and any previous sexually transmitted illnesses they may have had. Also want to ask about substance abuse, smoking, drinking, recreational drugs, IV drug use. Figure out their domestic living situation. Who do they live with? Do they feel supported? Are they, do they feel safe where they're staying? Are they worried about domestic violence? Are they employed? Do they have food insecurity issues? Depending on their insurance funding status, we have resources that we can help patients with copays or get them into Ryan White. So those things become important. And then psychiatric history, I think depression is a really big one. And depression and substance abuse kind of go together anyway. So it's such a life-changing, life-altering diagnosis that for folks that are kind of on the edge of depression or, they do some recreational drugs, those things can really be ramped up with dealing with the stress of being HIV positive on top of all that. So those are things we want to assess for in the history. Any questions before I move forward?
No,
I
ma'am.
don't think so.
Okay, and then in terms of physical exam, HIV can affect every single organ system, but I'm only picking a few that I think are relatively easy for us to pick out. So this is, which of these is an ophthalmologic emergency?
Ooh. I think,
I don't know.
I don't know. A looks bad to me. So.
Yeah, A does look bad. Anybody have a guess as to what A is?
Like a bleed.
I
I don't know.
Did I hear someone say a bleed?
Yeah.
A bleed, yeah.
So there are retinal hemorrhage, that red stuff, or that's retinal hemorrhage.
Right.
So,
Right. Those are.
yeah. So it turns out that these are both ophthalmologic emergencies. The one on the left is CMV retinitis, and the one on the right is progressive outer retinal necrosis, which is the only time I'm going to talk about porn in the context of a lecture.
Okay.
So CMV retinitis, so what you're seeing, that red stuff are the retinal hemorrhages, and the yellow stuff are infiltrates. So sometimes it's people will refer to this as a scrambled eggs and ketchup appearance. I don't know if it looks like that to you guys. And the way that patients present, it can be incredibly variable. Some patients can be completely asymptomatic, which is why anybody with a low CD4 count automatically needs to see ophthalmology no matter what, whether they have symptoms or not, to rule it out. Because if you get it when it's asymptomatic, that's the best prognosis for that patient. Or they can see floaters, have visual field deficits, see kind of flashing lights, scotomas, have problems with their visual acuity. So this is something that for brand new patients, I have no idea what their CD4 is. I always look in their eyes. It's not going to look beautiful like this because you're going to be looking into a non-dilated eye. But if you see anything that really looks abnormal, then that's, you know, an emergency ophthalmologic referral.
Right.
On the right is porn. So this is caused by necrotizing herpetic retinopathy from varicella zoster. And this actually leads to a rapid loss of vision. And you can usually see there aren't any hemorrhages or anything like that, but you can see some white lesions. And this isn't that great a picture for it, but sometimes it gives you kind of a cracked mud appearance. And this is obviously like an ophthalmologic emergency. So, and it's incredibly rapid loss of vision. And with both of these, once a patient starts having vision problems, you can't correct it. You can just stop the progression of it. So you can see that in terms of like eye-threatening issues, that if you're concerned about any of these, we need to be really, really prompt with getting them to ophthalmology.
Okay.
Okay, what about this one? Which of the following requires treatment with antifungals? A is the one picture at the bottom. B is the one on the right. Both or neither?
I think, well, first of all, it looks like there's significant pharyngeal involvement, so I would say that one probably is going to need an antifungal.
Mm-hmm. Right. So
is it both?
So it's definitely A, because that's oral thrush for sure.
Right.
What about B?
Right.
What do you guys think about B?
I'm not sure that that's thrush. I don't know.
No, you're absolutely right. It's not thrush. So
is it leukoplakia or something? Or?
It is. It is. So it's oral hairy leukoplakia caused by EBV, super benign. Is not anything you would treat with antifungals, and it's usually at the lateral sides of the tongue, and then there are hair-like projections that kind of shoot out. So so A, that's oral candidiasis. B is not. But oral candidiasis can look very different. So we normally see it as this top right, that's obvious oral candidiasis, but it can actually look like the bottom right, which is beefy red lesion. That is erythematous candidiasis. And then it can also look like the one on the left, which is angular cheilitis. So all of those you would treat with antifungals.
Okay.
So in terms of thrush, you can get this at higher CD4s, which is why it's not an AIDS-defining illness. And they're usually not painful. They usually don't bother patients. They're creamy white. The plaques you can scrape off with a tongue depressor. And the best prophylaxis against this is really just getting on intraocular therapy. So intraocular therapy will definitely take care of this and make sure that it likely doesn't come back, but we also treat this with fluconazole. And again, if they have oral candidiasis and they report having pain when they swallow, then you just assume that they also have esophageal candidiasis. And the treatment is pretty much the same, except it's a longer course. The treatment for esophageal candidiasis is 3 weeks.
Okay.
So which of the following is not associated with an AIDS-related malignancy?
C. I don't know.
Well,
no, I'll take that back.
I'm going to say E.
E?
But am I wrong?
E is absolutely right. So E is just periodontal disease. But A,
Yeah.
you see this is Kaposi sarcoma. And Kaposi sarcoma can be pretty much anywhere on the body, but typically it's inside the oral cavity or it's lower extremity. You can have Kaposi sarcoma on the skin. You can also have internal involvement of the lungs and the GI tract, the heart. But this is what it looks like in the oral cavity. So either like A, you have these flat macular lesions that are hyperpigmented and usually like brownish, purplish, dark. E, you also see this on the gum line. You can see it on the gums as well. D, they can also not be macular at all, and they can be nodular in appearance, which is what you see in C and raised in D.
Yeah.
And then this is what Kaposi sarcoma, most commonly in the lower extremities, looks like. Again, they can be macular. They can, when you palpate them, can feel a little indurated, or they can be papular and raised. Usually, if you have them on the lower extremities, because there's so much lymphatic involvement, patients can have like unilateral lower extremity edema, like you see down here as well. So those are definitely, there's so many skin manifestations of HIV, but these are probably like the most dangerous. Lots of other malignancies that go along with AIDS-associated malignancies, so primary CNS lymphomas with patients with super low CD4s of less than 50. And then as CD4s get higher, you worry about non-Hodgkin's lymphoma. At really high CD4s, you worry about Hodgkin's lymphoma and B-cell lymphoma. And then at kind of moderate CD4s, 200 to 500, you can still see cervical and anal cancers. And then usually Kaposi's we see at super low CD4s, even though it is theoretically possible to have at higher CD4s, but we almost exclusively see it with folks with low CD4s. These are some other things that you'll see. All patients are going to need kind of a GU rectal exam. So Pap smears are patients with HIV that are female are at higher risk for cervical cancer and cervical dysplasia. So they're definitely going to need to get their Pap smears done. Genital warts are incredibly common, and patients will come in and they'll complain of them, and there are medications you can give for this. You can send them to derm and they can try to freeze them off. So that's something else that we see a lot of. We usually screen for all kinds of STDs, but sometimes patients will come in with like a syphilitic lesion or a lesion of other sorts. And then also our patients are at higher risk for anal cancer. So you want to make sure that there aren't any anal lesions or masses as well. So in terms of opportunistic infections, if the CD4 is less than 200, we worry about pneumocystis, Jirovecki pneumonia. We can still call it PCP or PJP, whichever one you want. And usually patients with this, they'll have a progressive dyspnea, especially dyspnea on exertion. They can have a fever, non-productive cough, and some chest pain. It's very indolent, so it's not, if they wake up yesterday and all of a sudden they have these symptoms, they have PCP. It's usually over the course of several weeks that they'll notice these symptoms and that they'll get worse. And the way that we prevent this is anyone who has a CD4 count less than 200 gets on Bactrim for prophylaxis. And if for whatever reason, if they're truly allergic to Bactrim, so not just a mild, like I just have a little bit of a rash, but they really can't take it, they can't tolerate it, then we'll do Dapsone 100 milligrams daily for them for prophylaxis instead. We also do prophylaxis against toxoplasmosis as well. This is something that you see that affects the central nervous system with CD4s less than 100, and patients come in and they'll come in with confusion, altered mental status, headaches. They can have seizures and vocal neurodeficits and motor weakness from this. We usually do CT or MRI of the brain to be able to kind of diagnose it. But Bactrim also helps prevent toxo in patients with HIV as well. So we don't really see this unless they've never been diagnosed or they're just not taking the Bactrim. Mycobacterium avium complex is another opportunistic infection that we see at low CD4s, less than 50. And this used to be incredibly common before antiretroviral therapy. And now with antiretroviral therapy, it's pretty rare, but you will see it on patients that aren't on treatment yet. And their CD4s are usually very, very low. They complain of abdominal pain, diarrhea, maybe some nausea, fever, night sweats, weight loss. And the way that we prevent this is by giving patients with CD4s less than 50 azithromycin, 1,200 milligrams weekly, if their CD4 is low. These are kind of all the baseline labs that we typically perform on patients. We obviously do HIV testing if there's no documentation. We'll get CD4 viral load. It used to be that we would only do resistance assays in certain settings, like if we thought a patient was failing treatment, but now everybody gets resistance testing. And we screen them for STDs, we screen them for TB, we do an HLA-B5701 so that in case we want to use a backup we can. Screen them for hepatitis, for diabetes, lipids, in addition to the CBC chemistries as well. And then whatever age-appropriate cancer screening you would do anyway. So our patients' labs come back, CD4 is 25, and viral load is over 100,000. He meets indication for prophylaxis against which of the following opportunistic infections? Toxo, histo, malaria, MAC, or a combination of those?
Let's see. Yeah. Is it? Yeah. What did you say now?
It's for sure E.
Okay. We think E for sure. Is it? Hold on. I would say A, B, and E. So it's a letter G.
Yep. So it is A, B, and E. So because the CD4 is so low, you're going to prophylax against PCP, toxoplasmosis, and against MAC.
Okay.
I got it. So these are the big ones. PCP, thankfully, Bactrim is going to it's going to prophylax against PCP and toxo, and then the azithro for CD4 is less than 50. What else are you going to do for your patients with CD4 less than 50?
Let's see. What else? I mean, but just above and beyond these, correct?
Mm-hmm. Right. Something else that they're at risk for.
Cover them for candidiasis?
Well, you want to rule out asymptomatic CMV in these patients.
Okay. Oh, yeah.
So with the CD4 that low, you would also send them to the eye doctors.
Okay. Get their eyes examined. Okay.
And which of the following HIV-infected individuals should not be offered antiretroviral therapy? Somebody with an AIDS-defining illness, CD4 less than 350, 500, or over 500, someone who's pregnant, an elite control or non-progressor, someone who has HIV-associated nephropathy, hepatitis B co-infection, or everybody should be offered?
I'm going to say everyone should be offered.
Okay, I made this too easy for you guys then. I'm going to have to make it harder next time. No, you're absolutely right. Everybody should be offered. So there used to be this complicated dance of, you offer it depending on the CD4, maybe it depends on the viral load. And in 2012, all of that changed, which was everybody should be treated no matter what. And the reason for this is because what we know now is that the earlier you start people on antiretroviral therapy, the lower the rates of transmission to other people. There's near normal survival if patients have CD4 counts over 500. There's also a risk associated with just uncontrolled viral replication. Folks that have HIV, even with high CD4s, are still at higher risk for kidney disease, heart disease, and liver disease than folks with the exact same CD4 that are on medicines. So, so in terms of looking at their comorbidities and their mortality, there's a benefit of earlier initiation. There is always a concern that maybe if we initiated too early, that there would be more toxicity associated with the medicine, or they would get resistance, and that's just not what it's turned out. That's not what the literature tells us. Actually, folks do better. The newer medications don't have all the bad toxicities of the older ones, and there's actually less resistance, and patients are able to tolerate it much more. So I'm not going to go into a lot of the drug classes because I'm pretty sure that if you don't already have another talk about it, you're going to. But I wanted to just kind of go through just the recommended first-line regimen. So which of the following is an appropriate recommended regimen for HIV-naive patients? So A is efavirenz, tenofovir, and tricidovine. B is raltegravir, tenofovir, and tricidovine. C is atazanavir, ritonavir, tenofovir, and tricidovine. And D is maraviroc, tenofovir, and tricidovine.
I think B.
B is our guess.
Yes, and B is absolutely right, because if you don't already have this, if you will just Google HIV guidelines DHHS, you'll get the, I don't know, 200-page HIV guideline, but then they also have it bulleted and with a nice summary. And the integrase inhibitors, which are kind of our newest class medications, are they're incredibly potent, and they have the least amount of side effects. So really, in terms of if you're going to start someone on medications, it's going to be one of the integrase inhibitors. There is still a boosted PI, which is the darunavir in here. And you may want to consider using boosted PI if you're worried about adherence. But the integrase inhibitors, either dolutegravir, elbapygravir, raltegravir with something else, are kind of our mainstays. So I wanted to just kind of wrap up here in the 30 seconds I have left, just to say that, you know, in the way that we treat HIV has really evolved. It used to be that we were just worried about, you know, managing the crisis and getting people on treatment for opportunistic infections, but not really being able to do much. And then when antiretroviral therapy came out, kind of in the mid-90s, the whole focus was let's get as many patients on medications as possible. And now we're really entering this chronic disease era where HIV is a chronic disease like diabetes or like high blood pressure, and we're learning more about the long-term consequences of HIV that we didn't know about before. So I'm really excited that you guys are doing this, because the future of HIV is with you. The future of HIV is with transforming practices and integrating it with primary care.
Yes.
So I know we don't have tons of time for questions. Anybody with questions?
Hey, Jason, do you have
I don't think so.
I think that was really, really helpful, and we appreciate that very much, Dr. Patel.
Yeah, no problem. And I'm also available if you ever want to shoot me an email with a particular question. I would love to answer it, or if I don't know, I will figure it out and let you know. Okay. So yeah, just let me know if you guys ever need anything.
You bet. Is your email address in the? It's probably in the distribution, I'm guessing.
It should be, but if it's not, I'll ask Jennifer to send it out to you guys. Okay,
that'd be great.
Okay, thank you so much.
All right, thanks. Yeah. Thank you. Have a good day.
Good. Bye.
Bye-bye. All right.